So without further ado, introduce our webinar tonight, which is the role of vitamin B6, implications for hypophosphatasia. And joining us tonight, I'm very proud to be able to introduce Dr. Rush. Many of you are familiar with him, but if you're not, he's a clinical geneticist at Mercy Children's Hospital and the University of Kansas Medical Center, and an associate professor of pediatrics at the University of Missouri, Kansas City. He has a longstanding interest in rare bone diseases, including hypophosphatasia, and he enjoys educating and empowering patients about their disease. He's a board-certified internal medicine pediatrician and clinical geneticist. His research interests include extraskeletal manifestations of osteogenesis imperfecta and bone pathology in inborn errors of metabolism. Dr. Rush is a native Kansan and is happy to return to Kansas City last year after spending more than a decade in Nebraska. So Dr. Rush, thank you so much for joining us tonight, and we really look forward to your presentation on this very important topic.
Thank you, Deb. Can everybody hear me?
Yep, we can hear you great.
Perfect. So I'm excited to come to you tonight from a very cold and snowy Kansas City. And if in case anybody hears little feet tapping above my head, we've had no school for the past few days. And so we've had my children home as well as some other neighbor children. So we're gone from 3 kids running around our house to 7 kids running around our house tonight. So excuse any noises that you hear. So I'm really happy to be discussing the role of vitamin B6 in hypophosphatasia. This is an area that's of interest to me, and I know it's an area of interest to a lot of patients here. Oh, that was the wrong way. Okay. So we're going to go over a few things. One of the things that I want to discuss is the nature of B vitamins. What exactly are they, and how did we discover vitamin B6, and what do we know when you don't have enough vitamin B6 or when you have too much vitamin B6? We're going to talk about the neurochemistry of hypophosphatasia. I promise you we're not going to get in the weeds too much. And I also want to compare and contrast hypophosphatasia and a different inborn error of metabolism that I treat called PKU or phenylketonuria. There are some parallels that I've noticed over the last few years that I think might have some important aspects for how we take care of people with hypophosphatasia. And just in the interest of full disclosure, I have been and continue to be a consultant and speaker for Alexion, and I have been and continue to be a consultant for BioMarin Pharmaceuticals, which does not have anything to do with hypophosphatasia, but does for PKU. And some further disclaimers. So the first disclaimer is I practice science-based medicine, and so what that means is I follow not only the evidence, but I follow what we consider to be physiologic plausibility, which is a fancy way of saying it's got to make sense. And so we want to do things that make sense in medicine, and we want to do things that according to the evidence if that's possible. But unfortunately in rare disease, sometimes we don't have all the evidence. And so sometimes as a geneticist, I have to make decisions because I think they make sense, because I think they're compatible with the way we know humans work. And so the other aspect of this is that even though I try to practice science-based medicine, I'm still a person with my own biases. And so when I make an opinion in this presentation, and I will in several instances, this will be clearly labeled. I will try to let people know when I am editorializing in this case. Without further ado, so what is a B vitamin? So vitamins, in this case, the B vitamins, are just chemicals that are taken in the diet and that function as part of a body's metabolism. They help us go. So when you think about this, our B vitamins are taken in the diet to help things like enzyme processes, and we'll talk a little bit more about what an enzyme is. All those chemical pathways that you've heard about, they help them function. Without these vitamins, we wouldn't be able to make all of the things that humans need or that other organisms need to make us function properly. And so the B vitamins are just a collection of different vitamins that have different structures and different functions that are unified by the fact that they're all soluble in water. So there are some vitamins like B and C that are soluble in water, and then there are other vitamins like A, D, E, and K which are soluble in fat. We talk about vitamin D pretty frequently in hypophosphatasia and other bone diseases, but we're going to leave vitamin D on the shelf for tonight. and we're going to focus on the B vitamins, in particular vitamin B6. So this is a busy slide, and I don't expect anybody to take it all in at the moment. Hopefully you'll have access to this presentation. But my point in doing this is I want people to understand that there are a lot of different B vitamins, and they all have different functions. And kind of taking this to the next step of what I said in the previous slide is these help different parts of our metabolism work. In some cases, these B vitamins help us use our carbohydrates. These are things like starches and sugars. Some of them help us use different fats. Some of them help us break down proteins. And in the case of vitamin B6, which we'll talk about for the rest of the presentation, it's part of lots of reactions. And I'm going to focus really tonight on its function in making neurotransmitters. And although there are other functions to this this B vitamin, so how did we even discover vitamin B6? So it was actually it's amazing to me, thinking about this as a person practicing in the late 2010s, that there was so much that we were able to find as early as the 1930s with as crude of technologies as they had. But these scientists, even though they didn't have the technologies we do, they were just as smart as we are, probably more smart than we are today. And one of the things that has been done for a long time is we've used rats and mice as model organisms to help us understand how either diseases work or how different medications might work. And so in this case, in the 1930s, we had already discovered vitamins B1 and B2, or what we call thiamine and riboflavin. And these rats were fed this diet that we knew included those, but they developed a condition called rat acrodynia, which causes pain and sores in the skin. So acrodynia, acro means the ends of the body, dynia means pain. So this sounds like a really terrible condition, and I'm not a big fan of rats, but I wouldn't wish this on anybody. And interestingly enough, there were some animals that of other species were also observed under similar conditions to have seizures, which for those of us who know hypophosphatasia should start to sound kind of familiar. Eventually, they discovered a way to supplement with yeast extracts. So that's kind of a crude way of doing this, but they found that it improved this condition. What was eventually found is that vitamin B6 was in these yeast extracts and eventually was isolated in its pure form. And so, generally speaking, the reason why things got the number that they did in the B vitamins has more to do with when they were discovered than it does with any function of the vitamin themselves. So this is how we were able to discover what vitamin B6 is. But now that we know what vitamin B6 is, what do we do about it? Well, we know that having vitamin deficiencies is not good, but we also know that some vitamins can be toxic if you get too much of them. And so what we want is we want a person to have just the right amount of any vitamin. And in this case, when we have a person that has too little vitamin B6, we can see some problems that we're concerned about. One of these is anemia, not enough red blood cells to carry the oxygen around to the body. We get scaling and cracking of the skin, especially around the lips, around the corners of the lips, a condition we call angular cheilitis, which is very unpleasant. A swollen tongue can be present, and then also some of the neurologic complications that we're maybe a little more familiar with in the HPP community, such as seizures. And also, interestingly enough, depression and confusion have been described as a symptom of insufficient amounts of vitamin B6. Well, conversely, symptoms of too much vitamin B6 can include problems with the nerves. People can have a condition called neuropathy, where the nerves, particularly in the ends of their body, their hands and their feet, may not work exactly correctly. Sometimes this can cause pain. Sometimes it can cause numbness and tingling. And in some of these patients, they can also have a condition called ataxia, which means that you have trouble walking. And some people can also have skin problems, including sun sensitivity. So, of course, we don't want a person to have too much or not enough vitamin B6. We want them to have just the right amount. And where do we get that just right amount? Well, ideally, we get it from our diet. And so so vitamin B6 for most people in the United States eating a typical diet, we don't really have much risk of being vitamin B6 deficient because we find it in a lot of dietary sources: meats, dairy, some fruits, some vegetables. Chickpeas are actually a surprisingly high amount of vitamin B6 in them. And then things like soy and certain grains, particularly whole grains, can be a source of vitamin B6. So there's a lot of sources where you can get this. And you can also get this in supplementation. So you can get vitamin B6 in multivitamins. You can get it in a vitamin that's called a B complex, which includes vitamin B6 and a bunch of the other B vitamins. Or some people can take it by itself. Generally speaking, when we're thinking about the type of vitamin B6 in these vitamins, we're thinking about pyridoxine, and this is a distinction that will become more important a little bit later. What the difference is in the different types of vitamin B6. The other thing that I always caution my colleagues on is sometimes you can get enough vitamin B6 in energy drinks to raise your vitamin B6 level even in the absence of taking supplements via medication or anything like that. So your energy drinks, and I'm not picking on one brand here, do have a tendency to contain some pretty high doses of vitamin B6. So if you have so I always try to counsel my patients if they need to go off of vitamin B6 supplementation for a period of time. If they're an energy drinker, then they need to cut those out as well. And we're going to talk about some important terms because we're going to throw around a few terms, and I don't want to get too heavy into the terminology because really the terminology and the jargon is not so important and sometimes can get in the way of people understanding concepts that in some cases are not that difficult. But when the language is impenetrable, then it is difficult. So some important terms that I do want to talk about are terms like enzyme. So what is an enzyme? So an enzyme is a protein that helps a chemical reaction occur either more quickly or in a greater amount than it would otherwise. So when we have chemical reactions that occur in their body, we often can't wait for the chemical reaction to just happen by itself. And so we need that enzyme, we need that protein to come in and help that reaction along. And so enzymes are really important. And in this case, we're going to talk about we're talking about an enzyme called a phosphatase. In this case, alkaline phosphatase. So what does a phosphatase do? It's an enzyme that takes a group called a phosphate and it takes it off of a chemical. And it could be anything. So it could be any sort of thing floating around the body. If it takes that phosphate off, we call it a phosphatase. And the opposite thing can happen as well. When you have something called a kinase, that does the reaction in reverse. That adds a phosphate group to a chemical. And so these things often will exist in kind of a balance because a lot of times in the body you have need for a certain chemical that has a phosphate group or what's called phosphorylated, and sometimes it needs it without the phosphate group or dephosphorylated. And so you need both of these enzymes for it to function well. And definitely when we get to our question and answer period, if there's any of these terms or any different terms that are not clear to anybody and that you'd like me to further unpack, very happy to do that. Okay. And then another concept that I think is important is a concept called the blood-brain barrier. I think a lot of us have heard this before, but what is it? Well, there's a barrier between the blood circulating around the body and the brain, and this is a highly selective membrane that has these certain types of cells that are kind of surrounding the blood vessel, and a lot of stuff just isn't going to be able to get through that. And so the kinds of chemicals that can get through the blood-brain barriers are things that really need to get in the brain quickly. And these are things like oxygen. You've got to be able to get oxygen to the brain. You've got to be able to get certain hormones into the brain. And it keeps other substances out. And a lot of other things that the brain needs, instead of just kind of floating across the blood vessel like it does in other parts of the body, there are these little kind of pathways, these doors that we call transporters that help different molecules that the brain needs, and so that way the brain can really regulate what it wants here. Because the brain is another organ that you don't want too much of something, you don't want not enough, you want it to be just right. And the blood-brain barrier exists primarily to protect the brain from infections, because if a lot of these chemicals can get across, then so can bacteria or viruses. We don't want that, because when you get infections in the brain are no laughing matter. They're no fun, and they carry a really high complication rate. And and although people don't die from them as much as they used to in the pre-antibiotic area, they're still a big deal. So overall, the blood-brain barrier is a good thing. We want it because we want to be able to protect our brains from infections and chemicals that we don't want in our brain. But when we want medicines to pass through the brain, which sometimes we do, that makes life a little more difficult. So that is a quick version of the blood-brain barrier. And so I promise you that we talk a little bit more about the different types of vitamin B6. And these three forms are what we call vitamers. Which is a fancy way of saying different types of the same vitamin. So when we think about HPP, I think a lot of people have heard pyridoxal talked about, and its phosphorylated cousin, what we call pyridoxal 5-phosphate, or PLP. But there's these other forms as well. You have pyridoxine, which is the form that is mostly used in our supplements, our vitamins and things like that. And then we have a separate form called pyridoxamine, and it's just a little bit. These are all a little bit chemically different from one another. Well, what do we do with these? Well, we want sometimes we need them dephosphorylated. We need that phosphate group off of it, and that's where alkaline phosphatase comes in. And that's of course the enzyme that is deficient in patients with HPP. And when we take that phosphate group off of there, then you have a vitamin that's able to cross that blood-brain barrier. Whereas if it still has that phosphate group on there, can't do it. And so it's important to have these things exist in balance. And so you're able to make the appropriate amounts of both phosphorylated and dephosphorylated amounts of your vitamin B6. And there's a bunch of different enzymes that are responsible for this. And we've talked a lot about alkaline phosphatase in HPP and in previous discussions through soft bones, but we haven't talked as much about the pyridoxal kinase, which does the opposite reaction. And so again, we have to have things exist in balance. Balance is very important for the metabolism. And so why does this matter? And this is kind of going a little bit to what happens in the brain for people with HPP. So we know in the cases of a person with HPP, we know that alkaline phosphatase or ALP enzyme doesn't work very well. So the result of this is that not enough of this PLP, this pyridoxal 5-phosphate, is being turned into pyridoxal. Okay, so it's important to be able to make a certain amount of this pyridoxal so it's able to cross that blood-brain barrier. And then if you don't have enough of that pyridoxal to cross the blood-brain barrier, you can't then go ahead and rephosphorylate it within the brain so it can be used, because you need that PLP to actually be used in the chemical reactions. Well, what all does that do when you don't have enough PLP within the brain? Well, you're not able to make certain really important chemicals in the body. You're not able to make certain chemicals called neurotransmitters. And so neurotransmitters is not something I put in the terminology list, but I probably ought to have. And what they are different kinds of chemicals that help the nerves within the brain communicate with one another. And in many cases, these neurotransmitters are made from amino acids. And amino acids are those little building blocks of the proteins that are so important for us to have enough of. And this is where vitamin B6 can shine, is because it participates in those chemical reactions. It helps those enzymes work that turn certain amino acids into neurotransmitters. If you don't have enough neurotransmitters within the brain's not going to work that well. And the brain's a really funny and complex organ, and so the brain finds very different ways that it works, that it breaks down sometimes. Sometimes that's things like seizures. And in this case, this is what we believe the reason for the B6 dependent seizures in HPP are. So that's the basic neurochemistry. That's the basic issue of what's not working correctly in HPP. But what have we learned? What can we learn from a different disorder? And so even though this is soft bones and we talk about HPP, I'm going to take just a few minutes and I'm going to talk to you about a different disorder called PKU, or phenylketonuria. So this is a different inborn error of metabolism. Inborn error of metabolism, just like HPP, it's just a different enzyme. And for people with PKU, they're unable to turn a different amino acid into a different amino acid, or one amino acid into a different amino acid. And that's the exact identity of the amino acid is not really important. What is important is that if you don't treat PKU, bad things happen. People will develop intellectual disability, seizures, behaviors. They have poor pigmentation, pale skin, blonde hair, because one of the things that the tyrosine makes is it makes our melanin. It makes our pigment. And so if you don't have that, you can't make your pigment. And then these patients will also have a tendency to have skin rashes. And so can they educate about HPP even further? Well, probably because we know about PKU because we've had a highly effective newborn screening since the late 1960s. And so really by about 1968, all states in the U.S. had started newborn screening to identify the patients with PKU as early as possible. And so unlike the patients with HPP, where it's tough to sometimes get a few hundred people to learn about, we have thousands of people with PKU because we've been screening for them for many years. And this is my normal newborn screening from 1979. You can see in the lower right-hand corner, it's just a little check mark that says that I don't have PKU, which is good. And obviously today our newborn screening is far more extensive than the 2 check marks I got on my newborn screening from the Kansas Department of Health and Environment. And the part of this is the point of diagnosing, and this should say PKU. The point of diagnosing PKU early is so the diet can be modified as soon as possible. So when a person is identified as having PKU, within the first few days of life, they're evaluated, the condition is confirmed, and they are put on a special phenylalanine diet. Well, and this has been done for a long time. And so what we found out is that the patients who were started on diet and were kept on diet the first few years of life, they didn't have seizures, they didn't have the intellectual disability. And so up until about probably about the early 1980s, people with PKU generally were on diet until they were maybe 5 or 6 years old, and then they were taken off of diet. And so this actually turns out to be pretty important, what happened to them later. And I know what everybody's thinking, and it's probably this: what does this have to do with HPP? Well, I'm getting there. So those people that were on diet for the first few years of life and then went off of diet, they escaped the worst of the problems, but they didn't eliminate them. So what we found, and what I've noticed in treating adults with PKU, is that those people who have been off diet for many years started to report really similar concerns. They have poor focus, they have anxiety, they feel like their cognition is slowed, and they have lots of mood swings. And what we found is that the severity and the incidence of these findings has a lot to do with the level of the phenylalanine in their blood. So if people are not on diet at all and they have huge amounts of phenylalanine in their blood, a lot of these could be really bad. But if they were maybe on some amount of diet and maybe their phenylalanine levels weren't so bad, maybe their symptoms were a little milder as well. But it was clear to me that there were some similarities between what I was hearing from my adults with PKU and what I was hearing from my adults with HPP. Why? Could there be reasons for this? Well, we know that there are multiple reasons for that the brain doesn't work well in PKU. Some of this is because phenylalanine, if you have too much of it, is toxic. Some of it is you just can't build the proteins that you want to. But then this should really get our attention. Some people with PKU, some of the reason is they can't make their neurotransmitters. Now, if you'll recall a few slides ago, I told you that the reason why we think people with HPP get seizures is because they can't make certain neurotransmitters. Well, now we're starting to see some parallels here, and this is this is a very small subset of all of the steps that are required in making neurotransmitters from amino acids. Don't worry about all the details here. What I want you to look at is the two boxes. So the top box is what we see happening in PKU. So we know that in this case, we are unable to get adequate amounts of that tyrosine. We can't make that tyrosine, and that's not good. But also, when we have high levels of that phenylalanine, we also can't get a different amino acid called tryptophan to cross the blood-brain barrier. Okay, so we don't have enough tyrosine or enough tryptophan, and so we don't have enough of those chemicals to do that first step in the metabolism and make different chemicals called levodopa and 5-hydroxytryptophan. What's important for HPP and kind of bringing home that point is that you have to have PLP. You have to have that vitamin B6 within the brain milieu in order for that next step to happen. In order for that levodopa and that 5-hydroxytryptophan to become important neurotransmitters like serotonin, dopamine, norepinephrine. These are really important neurotransmitters to have. So because the vitamin B6 levels in the brain are likely very insufficient in many people with HPP, and because this is all part of the same common pathway, I think plausibly, and again, I've underlined this so you know this is my opinion, the net result of the pathway would appear that it could be common to both diseases. And so we might not be surprised that we're hearing a lot of the same complaints from our adults with PKU and in particular our adults with HPP. So with that in mind, this kind of brings up a couple of competing paradigms, and there are certainly more paradigms, more models of how we understand HPP disease, but kind of the traditional one has been that HPP is a bone disease, and all of its and everything that happens because of it are related to the bones. But there's a second idea is that HPP is an inborn error of metabolism. It affects multiple organ systems, and it can cause problems that are not limited to the bone. And so we have the ability to kind of collect other organ systems as being potentially involved with HPP. And this is a little newer one, and just happens to be the one that I think matches the facts a bit more, because we already know that there can be neurologic involvement in HPP with patients with our B6 responsive seizures. We know this, and so, but this has really been the only thing that has been attributed to HPP in the past. So the assumption has been that if a person with HPP escapes those seizures, there is no neurologic involvement. But do we have evidence of this? Is there evidence to support this idea or evidence to refute this idea? And especially in a disease like HPP that has such a broad range of symptoms and such a spectrum of disease, it seems a little unusual that there would be this sharp demarcation where a person either has seizures or doesn't have anything at all. So in my opinion, this is an area that has not been adequately studied. And so we really can't draw any conclusions about the nature of the neurologic involvement. But I also think that there is good reason based on the biochemistry and my experiences to be highly suspicious that there is still much to uncover. And I believe this is a crucial area for research. Again, my opinions are underlined. But I do believe that. And so what do we do about this? And so this is just in the last couple of minutes. I've kind of thrown a lot of hypotheticals, a lot of theory, and a lot of biochemistry at the audience, so people can kind of understand what my thoughts are on vitamin B6. But I also want to be practical in some respects. And so what do we do with vitamin B6 supplementation for people with HPP? Well, in only one subset is that really clear. So certainly patients with vitamin B6 responsive seizures, they should be treated with vitamin B6. But patients without vitamin B6 responsive seizures who are not on enzyme treatment, I think that their risk-benefit ratio is unknown. Why is that? Is because we don't really know how that extra vitamin B6 for those people without seizures, how much of that is getting into the blood across the blood-brain barrier into the brain, and what will it improve within the brain. And we also know that the excess vitamin B6 can be toxic, and so we might be in the situation where a person with HPP may simultaneously have evidence that they have toxicity of vitamin B6, too much vitamin B6 outside of the brain, and yet not enough within the brain. And so everybody's probably aware of the Hippocratic Oath, which has a lot of tenets, but one of them is first do no harm. And so the way I interpret do no harm is that we have to have a very clear sense for risk, and I don't like to put my patients at risk and so for those patients with vitamin B6 responsive seizures who are not on treatment, I think we have that undefined risk-benefit ratio, and that makes me very nervous. Mm-hmm. So what about patients with without the seizures who are on treatment? Well, I also think they have an undefined risk-benefit ratio for other reasons. So because we assume that some aspect of their normal B6 metabolism should be restored on the enzyme, we think probably the amount of B6 a certain amount is getting into the brain, but we have a different issue here. So in this case, we have less risk, but we also may not need it because we may already be getting enough vitamin B6 into the brain. So again, lower risk but lower potential benefit. And so I think it's very likely that patients who are on treatment, the vitamin B6 is probably of less risk, but again, we may also receive less benefit from it. So if you can't use the B6 you're taking, you may have more risk than benefit, and if you can use the B6, you may not need it. And so I will say, and I understand that this recommendation or this statement will probably be frustrating to many people in the audience, and I get that, I definitely do, is that I don't think we have enough evidence to make specific recommendations on dosage and on who are the people, aside from those people with B6 responsive seizures, who should be on supplemental B6. We will get there. I believe that we will get there and we will know about this, but at this point, I have to go err on the side of caution and say we just don't know yet. And so that's kind of the practical aspects of this. And so in short, I want to thank everybody for their attention. These are my three kids smiling at the Nelson Atkins Museum here in beautiful Kansas City. On a much nicer day than today. So I really appreciate the opportunity from Softbones. Thank you to Deb and the rest of the Softbones group for being very supportive of myself and the HPP community. And I really appreciate the opportunity to get to talk about this. So please, if there are any questions, I am more than happy to answer them.
Okay, can you hear me now? This is Deb.
Yes.
Okay. We did get one question here. So now that my alkaline phosphatase went from low 17 to 10,000 because I'm on, enzyme replacement therapy, will a V8 or VD6 be valuable?
Yeah, that's a really good question. So I think based on what we know from the studies, from the vitamin B6 levels in people that were in the studies, I think we have a sense that even though the enzyme replacement is targeted towards bone, that it does seem to at least partially restore the vitamin B6 metabolism. So we would presume that that people who are taking that would have additional vitamin B6 within the brain. How much of that we don't know. Is it a certain percentage of the average, or is it still much lower than the average? I just don't think we know. So I think from a biochemical standpoint, we can say, yeah, you probably are making more of that pyridoxal because of your enzyme. But how much is that getting in the brain, and what is its net effect? I don't think we quite know that yet.
Yeah, we get questions all the time about supplementation and what forms of B6. If somebody may be suspecting that they should be supplementing B6 and they want to try it, working with their doctor.
Right.
Do you have any kind of guidance for them about things to be on the lookout for what kind of B6 is the best kind of to supplement with, and, what is kind of a general protocol, because there's, patients who share stories that they're supplementing, and then others that are, thinking that might be something they want to try, but, they're kind of wondering what to be on the lookout for. Do you have any guidance for them?
Right. And so I think if a person is very compelled if they just really want to try vitamin B6, then what I would say is do so in conjunction with your doctor. I would start at a low dose. Most of the supplements are start out at around 25 milligrams. But you start slow and look for toxicity. So if you start having numbness and tingling in your hands, if you start noticing that or your feet, or if you start noticing that you're sensitive to the sun, these are signs of vitamin B6 toxicity, and then you know that's so that you need to back off. Again, I'm uncomfortable issuing any formal recommendations for this, but if a person is very compelled to do this, this is one way that you could kind of minimize the harm. If any, because at the end of the day, I don't want anybody to be hurt.
Exactly. Another question. My 14-year-old son is on enzyme replacement therapy and has chronic cracked and peeling lips, which isn't happening from dehydration. Should his doctor check his B6 in a blood test?
Yeah. Ordinarily, you might think that would be a good idea. Unfortunately, one of the enzyme replacement is so active that it doesn't stop acting just because it's not body. So you'll metabolize your vitamin B6 in that blood tube even when it's chronic. So that enzyme replacement is there. So a lot of times, if you have a person who's on enzyme replacement and you check a vitamin B6 level, it's low. That doesn't mean it's actually low. What it means is it's been sitting in the tube and continuing to chew up that vitamin. So for actual vitamin B6 levels is limited. There are inhibitors that you can put in there to kind of stop the action of the enzyme replacement from working, so you can get an adequate sense of vitamin B6 level in the body. I think if a person is having cracking and peeling around the lips and kind of that condition we call angular cheilitis, which is really painful, I think that you may plausibly have a person who's showing signs of peripheral B6 deficiency. So in that case, do you wonder, is this a case where a person's chewing up all of their vitamin B6 that was kind of accumulating in their body, and now they've kind of gotten hungry for more vitamin B6? I don't know if that's true, but if this is a person who's having an actual health problem because of this, you might talk to your doctor about whether they think it's reasonable to do some cautious investigation and maybe some supplementation in that case.
Okay, the next question is around nutrition and B6. So this patient saying that a nutritionist is telling her not to limit her B6 intake. She's not on treatment. She's been diagnosed with HPP and has high B6 and a 13 ALP. I mean, do you recommend that people adjust their B6 intake if they're already trending high and are not on therapy?
Yeah, I haven't recommended that. I haven't recommended supplementation, but I haven't recommended eliminating the B6 from the diet, because in some sense we still need it, right? And my concern of over restricting B6 from the diet is this. So I'm trying to think of how to do this, so how to explain this so it makes any sense at all. So there's a concept in that I learned as a freshman in college in chemistry called stoichiometry. And the idea here is that there's always going to be a balance of chemicals on each side of your reaction, and that there's a lot of ways that you can push your reaction forward, or that you can make it so it doesn't go forward as much. So you're not making the reaction go. And one of the things that can make the reaction go is by slamming a person with a bunch of a certain chemical. But then one of the ways that you can make so the reaction doesn't go as well is to really limit the amount. So again, I'm not super excited about having just tons and tons of vitamin B6 floating around in everybody with HPP. But my concern is that if you restrict it too far, you may have such a little amount of B6 in kind of total in the body after a while that whatever enzyme is still functioning there and making those small amounts of pyridoxal that are going across the blood-brain barrier, you may not be able to do that. And so I'm just concerned about over-restricting that you may actually cause additional problems there. So again, nobody really knows what the exact right answer is here. And so I've kind of been walking sort of a safe middle line by saying we can't really make good recommendations on B6 supplementation in sort of pill form, but neither can we say you need to restrict vitamin B6 in your diet. So I'm not making that recommendation.
Okay. Another question: Does high B6 without treatment control the production of ATP?
Does it control the production of ATP?
Yeah.
No. No. The ATP is made through many different pathways through the body. And for those of you who haven't heard of it, ATP is a really important molecule that we use as a store of energy. So kind of our metabolism is based in large part on on kind of using that ATP to get energy for all the things that we do. But there's lots of different ways that the body makes ATP. So I wouldn't say that. So is vitamin B6 involved in some of those pathways? Absolutely. Is it ultimately responsible for all of the production of ATP? No, I wouldn't say so. And for that matter, I don't know that we really have a clear picture on kind of what high B6 does for amount of ATP produced, if anything. I just don't think we know.
Another question here: does B6 in the brain have a role, you think, in headaches? Because a lot of people with HPP seem to complain about headaches. Do you think there's any connection there?
Well, there might be. I mean, I think it's plausible. So, again, when I was talking about science-based medicine, one of the things that I mentioned was that when we don't have evidence, we like evidence. Evidence is good, and we should practice when there is evidence. But when we don't have evidence, sometimes we have to do things because they make sense, because they align with what we understand about how humans work. And so I think for this, some of the things that I see in patients with HPP, like mental illness, such as anxiety and depression, like headaches, like feelings of cognitive slowing, I think these are plausible, to be part of that neurologic phenotype. We don't know this for absolute sure, but they're plausible.
Okay. Here's another question about somebody who's having B6 seizures and is on pyridoxine 500 milligrams a day, and the seizures slowed but are still there. Anything else that you would do to help to control the seizures?
I'm sorry, anything else that you can do to control the seizure? Was that the question?
They're on pyridoxine 500 milligrams a day, but the seizures have slowed but haven't completely been eradicated. So would you have any recommendations? 500
milligrams is a lot of vitamin B6, and not knowing how old this person is or how much they weigh, it's hard to weigh in on exactly what kind of a theoretic maximum dose is. One of the things that I might suggest to that person who has incompletely controlled B6 responsive seizures is there's the possibility that they might have another seizure disorder on top of that. So if a person has incomplete control on what we consider to be an optimal dose of B6 but is still having seizures, maybe they have a second reason for having seizures. And so I encourage people in that instance, talk to your neurologist and see if there's any suspicion that this could be true, if there's anything that they would recommend to further evaluate for this, and if there's anything different that they would do for treatment.
Okay. Another question about B6 in our brains and how it could potentially impact, the whole metabolic function, potentially serotonin and, possibly having connection with anxiety and depression. Knowing that, do you think that there's any reason to believe that depression medications would not work in HPP patients?
No. I think everybody responds to those sorts of medications a little differently. But I think for any of us who are on medications that affect the neurotransmitters, and all the medications that we would use for depression affect one or more of the neurotransmitters, predominantly serotonin and norepinephrine, but also to some extent the dopamine cycle as well. And so, because they generally work to increase the amount of available neurotransmitter, that should contribute to improvements regardless of what the absolute value is, right? And so if a person, even if they have relatively low amounts of these neurotransmitters floating around, if you can increase them, that's still probably for the good. So, might they not get as good of a response as another person? I don't think we know, but I still think they certainly have a use.
Yeah. I just have a kind of a practical question, because not all of us can go to you, Dr. Rush. So, I appreciate your advice to talk to our doctors, but, not all doctors may be as knowledgeable or as bold to, be willing to take some of these steps. Do you have any guidance for some of the patients who maybe aren't getting answers or feel that there should be some supplementation going on, but doesn't seem to have the partnership with the physician? Do you have any advice on how to manage that situation? And do we have any published data that could be potentially shared to help educate these doctors?
That's a great question. And unfortunately, that's one of the areas we're lacking is in published data. So, so much of this that I talked about is hypothetical. And that just happens to match what I'm seeing in patients. So I think that each doctor has to practice in a way that they are independently comfortable with, and we can't really, patients can't always compel their doctor to see things their way, and frankly, we as their peers can't make them see things our way. So I think that in the absence of finding somebody who is who has a special interest in HPP, I do have a bias for physicians who, by temperament, are more collaborative. I find these physicians tend to be younger, and so I think that part of this is just the differences in medical training. Part of this is a difference in it's kind of an embrace of a team approach. And also just a kind of a different type of person that tends to go into medicine now than 30 years ago. So I think your older docs, and I have a lot of really wonderful older colleagues, and so I don't mean to say that older physicians are not good physicians. That's not what I'm saying at all. What I am saying is I have noticed a trend towards younger physicians being a bit more open-minded, being more willing to collaborate, and being willing to have a really collaborative care relationship with their patient. Your mileage may vary, but that may be of assistance for people who are looking for providers.
Yep. Yeah. Here's another question, similar to the question before about the headaches. Do you feel that B6 levels can be responsible for the adult HPP patients that have seizure-like activity, migraine-induced seizures, spells, et cetera, that have not been fit to any particular diagnosis?
And again, that's we have a testing paradigm for seizures and hypophosphatasia. And so again, it seems plausible that this may exist, like all other aspects of hypophosphatasia, quite frankly, along a spectrum of severity. So what would be ideal in these cases is to for us as clinicians to start collecting hard data on this. Because that's one of the things that we struggle against is just not having a lot of this information. And regardless of what I say or what I think, at the end of the day, the physicians are still going to want the data, and I don't blame them. I wouldn't trust some random doctor from Kansas telling me what I should and shouldn't do. And so at the end of the day, we do need data, and that data starts with patients reporting what they're experiencing and starting to collect and report that in an organized way. I think that's really crucial.
Yeah. What's your theory on hormones and the role that they play when you have B6 seizures? And I know that you and I have had conversations about perimenopausal women and how they're people of interest. Are there other hormones that you think also come into play with B6 that could potentially exacerbate the B6 involvement?
As far as hormones are concerned, I tend to view the steroid hormones as being more indirectly related to overall bone health. And so, estrogen and testosterone are both good for bone. And so when they are no longer present, you have the issues of low testosterone or low estrogen. And because developing low estrogen over time is a normal part of aging, as opposed to developing low testosterone over time, which is a little bit of a different entity. So in that perimenopausal period, we see. My concern is that we're seeing a kind of a layering on of a normal physiologic process in menopause on top of an abnormal physiologic process. I don't know that we're seeing a similar phenomenon happening between hormones and B6. It might be that it does. It's just not something I'm aware of.
Okay, I think we have time for one last question here. Here's a question about, would you consider, this is a patient's perspective, would you consider my broad definition of a seizure as a muscle spasm that would take my breath away, chronically contracted cement-like muscles that are protecting the fragile bones, making movement difficult or impossible, also electric shocks, jolting? So it's just a question of your view on seizures. Are they purely neurological in the brain, or can they be muscular?
Well, you can have a what's called a partial seizure, where you have maybe one part of your body is moving or is affected, and so it's true that a person could only have one arm or one leg affected, and that could still be a seizure. But also, not everything that causes contraction or causes movement that's abnormal or causes spasm, a lot of those things are related directly to the muscles themselves, and even in a localized way. A lot of them are related to the muscles themselves. And so I don't know necessarily if this patient is having a seizure. They could be, but I would ask them to be open to the possibility that this also may be a muscle-related process. And in connecting with that person's healthcare provider, I would certainly encourage them to consider all the possibilities and consider both seizure and non-seizure related reasons for that issue.
Well, I want to be respectful of everybody's time, and we're right upon the hour mark. And I really wanted to thank you, Dr. Resch, for imparting your wisdom upon us and sharing your expertise. It's really, I know you've answered a lot of questions that we get very frequently, and this was a topic that came up when we just did our patient engagement survey as something that was of high interest. So I know that the webinar that's going to be available online will be in high demand. So thank you for taking the time away from your beautiful children that we're looking at on the screen tonight. And we really appreciate all of your support in working with soft bones and supporting our hypophosphatasia patients.
It's a pleasure to be a part of this.
Thank you. All right, everybody. So again, I talked about the survey. If you haven't taken it yet, please do so. We're going to be closing it up by the end of the month. And thank you, everybody, for joining us. Have a great afternoon and rest of your evening.